permission to start the class?
Yes, start please.
Respected Independence Awardee, Brigadier General Professor Nurun Nahar Fatima Begum, Honorable Vice Chancellor Bangabandhu Sheikh Mujib Medical University, Senior Consultant Pediatric Cardiologist, Square Hospital Bangladesh Limited, Professor ADM Abdul Salam, distinguished participants from home and abroad, ladies and gentlemen, Assalamu alaikum and very good afternoon to you all. It is indeed a great honor and rare privilege for me to be present here in this evening as moderator. I take this opportunity to express my sincere gratitude and warm felicitation. I welcome you all again to our today's class. Topic of our today's class, tricuspid atresia. Our today's speaker will give special emphasis on its anatomy, physiology, pathophysiology, hemodynamic aspect, embryological aspect, clinical features, investigation, particularly in echocardiographic investigation, and finally its management perspective. Our today's speaker, Professor Dr. Ferdowsur Rahman Sarkar. Professor Dr. Ferdowsur Rahman Sarkar has completed his graduation in medicine from Rangpur Medical College in the year 1992 under Rajshahi University and securing second position. In the year 2003, he has completed his diploma in childhood from Dhaka University. In the year 2007, he has completed his fellowship in pediatrics from Bangladesh College of Physicians and Surgeons. In the year 2008 and 2009, he has completed his fellowship in pediatric cardiology from Narayana Health, Bangalore, India. And after that, he has undergone advanced training in pediatric cardiac intervention from Mehmet Akif Cardiac Research Center, Istanbul, Turkey, in the year 2015. Now, he is working as a professor of pediatrics and pediatric cardiology at Combined Unity Hospital, Dhaka, Bangladesh. Now, I would like to request Professor Dr. Ferdowsur Rahman Sarkar to deliver his speech. Dr. Ferdowsur Rahman Sarkar.
Thank you, Lieutenant Colonel Nazmul, for your kind introduction. Assalamu alaikum, respected Independence Day Medal awardee, respected teachers, and my dear fellow colleagues and students. I welcome you all to my today's topic, and I am very much grateful to our respected HOD and Independence Day Medal awardee, the pioneer pediatric cardiologist of Bangladesh, Brigadier General Nurun Nahar Fatima Madam, for her kind generosity to include me in this online training session as a faculty. Our today's topic is the spectrum of the tricuspid atresia and individualized management. But before going to the topic, I will take you a couple of minutes to talk on the univentricular heart. The term functionally univentricular heart encompasses a group of cardiac malformations defined by the presence of
slide.
Madam?
Slide দেখছেন না।
Slide দেখা যাচ্ছে না, madam?
না, share your slide.
Okay.
Maybe slide has not started yet, ma'am.
Okay. Let me check it again. Madam, again I'm joining.
স্যার কার্সারটা মুভ করলে দেখতে পাবেন শেয়ার স্ক্রিন আসবে স্যার কার্সারটা মুভ করলে নিচে শেয়ার স্ক্রিন আসবে
এখন কি দেখা যায় ম্যাডাম
হ্যাঁ 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 yes
Now it's visible.
Okay, sorry for the technical error. Now it is visible, ma'am.
yes please
Okay.
continue.
So today's topic is the spectrum of the tricuspid atresia and its individualized management. But before going to the topic, I will take you a couple of minutes to talk on the univentricular heart, because this terminology is a misnomer and actually it is a misleading. According to the Van Porak, it is inappropriate to term the heart as univentricular because all mammalian heart are developmentally and embryologically biventricular. But then the Anderson, who is the pioneer in, defining the different classification center terminology in the pediatric cardiology textbook. Alexander Anderson, he actually termed these conditions as the functionally univentricular heart because the heart is developmentally always biventricular, but then the terminology still it is in use in many textbooks and by the many experts. So we have to understand actually what is the problem with the terminologies. The term functionally univentricular heart encompasses a group of cardiac malformations defined by the presence of a single ventricular chamber or a large dominant ventricle associated with a diminutive of the hypoplastic opposite ventricle. Then we have to understand what is a ventricle of the heart. A ventricle of the heart is a chamber which is lined by the endocardial tissue and which has got both the inlet, outlet, and the trabecular part. This is called the tripartite. But when there is the abnormality either in the inlet or in the outlet, then the development of the trabecular part is hampered. And if the chamber receives the 50% rule, like that of the blood vessel, that if a chamber is complete, when it receives the more than 50% of the inlet. When there is the problem with the inlet, that is, it receives less than 50%, then the chamber development will be hampered, and the chamber is called the rudimentary chamber. But developmentally, the chamber is started during the early part of the cardiac development, but because of the ongoing problem, the chamber development may be diminutive or maybe hypoplastic, or it may be rudimentary. That's why the Anderson termed this condition as a functionally univentricular heart or functionally single ventricle. And the conditions where we can get this functionally univentricular heart. So I have already mentioned that there is the problem with the either inlet or the problem in the outlet. If there is the problem in the inlet, the conditions we might get where the right-sided inlet may be absent, the condition like your tricuspid atresia, or there may be the left-sided inlet may be absent, the condition we get in mitral atresia. Besides, there may be double inlet, where we can get both the inlets committed to a ventricle, and most common is the double inlet left ventricle, or maybe double inlet right ventricle, which is very rare. And then the inlet may be of a single. This type of pathology we actually see in the atrioventricular canal defect or AV canal defect with a unbalanced ventricle, where one ventricle is dominant and another one is hypoplastic. So besides the inlet, what is about the outlet? So when both the outlets of a ventricle, of the ventricles, we know that the outlets of the right ventricle is the pulmonary artery, and the outlet of the left ventricle, it is the aorta. But when both this outlet or the aorta and the pulmonary artery are committed to a single ventricle, we can get the conditions like in DORV, where both the outlet or both the aorta arising, both the arteries arising from a single ventricle, we call it DORV, where the RV is dominant and the LV is hypoplastic or rudimentary. In conditions where both the outlet of the left, both the outlets are committed to the left ventricle, the condition is the DOLV, and then in that particular case, RV is hypoplastic and the LV is dominant. And when the outlet is completely absent, like in pulmonary atresia, we can get the dominant LV and hypoplastic RV. And in aortic atresia, we can get the dominant RV and the hypoplastic LV. These terminologies will come. This is very much important in the management and the subsequent, whether it is a surgical management or the medical intervention. Now the tricuspid atresia. Tricuspid atresia, it can be defined as a complete absence of the tricuspid valve with no direct communication between the right atrium and the right ventricle. There is some degree of the hypoplasia of the right ventricle as mentioned, and obligatory right to left shunt at the atrial level is mandatory for survival, and communication between the systemic circulation and the pulmonary circulation should be there, usually in the form of a PSD, or if there is associated pulmonary atresia, then the pulmonary blood flow is usually supplied by a patent ductus arteriosus. This complex anatomy, the incidence is less than 3% of all congenital heart disease. It occurs at 0.56 per thousand live births. And there are other multiple cardiac anomalies may be associated, less than 25% of the patients. We'll talk about it later on. Now, what is the history of this tricuspid atresia? This anatomical conditions was first described by the Kruszik in 1817. So the clinical features reported by the Ballet and the Stewart in 1933, and also by the Taussig-Bing and Brown in 1936. So the cause of this defect is still unknown. It is a multifactorial disorder, as with the other congenital heart disease is multifactorial like this. And for this particular specific disease, no specific genetic marker responsible for this defect has been found as yet. Now, what is the embryology? We know that the tricuspid valve developed from the endocardial cushion and the mesenchymal cells. The atrioventricular cushions derive their mesenchyme from the endocardium through a cellular process called the epithelial to mesenchymal transformations. That is called the EMT. And the fusion, so like the development, when the heart starts its early development, there is a common atrioventricular canal, like heart develops with a common tube, then it divides into two, and subsequently the other organs or other parts develop like this. So initially there is a common chamber, then this superior and inferior atrioventricular cushion, this fusion and remodeling of the atrioventricular cushion together with the mesenchymal cells causes the development of the tricuspid valve as well as the development of the mitral valve, and both these inlet are formed, and it is usually formed between the 34 to 36 days of the intrauterine life. And this tricuspid valve, it has got the three leaflets. We know that anterior leaflet, septal leaflet, and the posterior leaflet. Amongst which, the anterior leaflet is the largest, and it attaches to a single papillary muscle. Septal leaflet is the attaches to the RV valve by the chordae, and posterior leaflet, which is the smallest of the three, and it is also there. But then these three leaflets, as you can see, these are not in the same plane. If you do an echocardiography, you cannot see all the three leaflets in a single plane. You have to do certain maneuver of your transducer to see the posterior leaflet, because if you see the anterior chamber, you only can see the anterior and the septal leaflets. But then in a short parasternal short axis view with posterior tilting, so you can be able also to see the posterior leaflets. And the tricuspid valve, it is the largest of the four cardiac valves. We know that there are four cardiac valves in the heart: tricuspid, mitral, the aortic, and the pulmonary valve. And the tricuspid valve is the largest of the all four valves. The normal tricuspid valve complex, it includes a fibrous continuity, it includes a fibrous annulus. There are three leaflets: the chorda tendineae, the papillary muscles, and the RA and RV myocardium. The tricuspid valve annulus, it is actually asymmetrical and saddle shaped, and when it is viewed from the RV cavity, it looks like inverted D. But at the mid leaflet level, the tricuspid valve annulus is triangular. And then tricuspid valve annulus, it is more compliant than that of the mitral valve and the other valves that allow it to change with the varying loading conditions. The tricuspid valve, what are the pathologies that can take place in the tricuspid valve? Number one is the atresia of the tricuspid valve, where there is no tricuspid valve at all. A tricuspid valve may be stenosed. So valve is developed, but then there may be the hypoplasia of the annulus. There may be hypoplasia of the chorda or hypoplasia of the papillary muscles, or the components of the tricuspid valve may be hypoplastic. So it makes the valve stenosed. There may be displacement of the septal leaflet of the tricuspid valve and the other leaflets, tethering and lengthening of the anterior leaflet. So that these conditions finally we may get in the we usually get in the Epstein anomaly and the tricuspid valve regurgitation. Although the trivial to the mild form of tricuspid valve regurgitation is common, and it is seen in about 75 to 80% of the population, but more than mild or moderate to severe tricuspid valve regurgitation is almost always pathological. Then you have to look for either the Epstein anomaly or the conditions I have mentioned, the three leaflets and the annulus or hypoplasia that may cause your leakage from the tricuspid valve. Then the tricuspid valve atresia, our previous topic is the atresia of the tricuspid valve. So I will concentrate on this. The atresia of the tricuspid valve secondary to the formation of the muscular tissue, it is most common. There is no tricuspid valve, rather this area is completely covered with the muscular tissue. It is about in 90% cases we get. There may be no tricuspid valve. There is a fibrous thickening of this particular area. This is the next common type, which is about 6 to 9%. And the tricuspid valve may be developed, but then there is diffusion of the leaflets, so there is no inflow, and then this condition we can get in 1% of the cases. And another is very rare, that is called the atrioventricular canal type that we get in the AV canal defect, where the A leaflet of that AV canal defect actually completely seals off the only entrance from the RA to the RV. And this is very, very rare. It is present in about 0.2% of the total tricuspid atresia. Then if there is no VSD, Then the right ventricle is rudimentary or maybe absent entirely. In these particular conditions, the tricuspid atresia is also associated with the pulmonary atresia. Now we have talked about the inlet, and now let us talk about the outlet. So what is the problems with the outlet besides the double outlet? So in the outlet, what happens? The flow of the pulmonary artery may be unobstructed when there is the large VSD and there is no stenosis in the pulmonary valves or in the infundibular regions. The pulmonary blood flow may be restricted, in particularly small when there is a small VSD, or if there is the pulmonary valve stenosis or the pulmonary annular hypoplasia or the RVOT hypoplasia. And then the pulmonary artery may be completely absent, then it is called the pulmonary atresia. So the outflow, the flow of the outflow in tricuspid atresia is very, very important for the management aspects and also for future planning of the subsequent complete, the management. So because of this diverse complexity of the conditions, the tricuspid atresia, it is usually classified into 3 types. And then these 3 types are called the type 1, type 2, and type 3. Type 1 and type 2 is actually related to the blood vessels relationship. When the blood vessels are normally related, then it is called the type 1. And this is the most common. It is about 70 to 80% of the total tricuspid atresia. And this tricuspid, this type 1 is again subdivided into 3 depending on the outflow. Outflow, if there is the intact ventricular septum with the pulmonary atresia, then it is called the type 1A. When there is a small VSD and there is pulmonary stenosis, and it is called the type 1B, which is the most common type of tricuspid atresia. And then when there is a large ventricular septal defect and there is no obstruction to the pulmonary blood flow, then it is called type 1C. So here you can see there is no obstructions, and then it is called the type 1C. And tricuspid atresia type 2, if the blood vessels are transposed, that is when the aorta arises from the RV and the pulmonary artery arises from the LV, then the great artery is transposed, and this type of the conditions with tricuspid atresia, it is the tricuspid atresia type 2. And the other subclassifications like that of the type 1 is same, that is when there is pulmonary atresia or total outflow obstruction, then it is called type 1A. When there is pulmonary stenosis and there is decreased flow through the pulmonary circulations, it is called type 1B. And then when there is the large ventricular septal defect and without stenosis or overflow into the pulmonary circulations, then it is called the type 1C. Then the type 3, actually this type 3 is not, separately discussed in the text, but then these conditions, when the blood vessels are either transposed or malposition of the blood vessels, and this condition is also associated with other complex lesions like truncus arteriosus, atrioventricular septal defect, or the corrected transposition, the corrected TGA. So these conditions is labeled as the type 3. You can see here in the CT angio view that there is the ventricular inversion, the LV is on the right side, RV is on the left side, and the atrioventricular connection, the RA is connected to the LV and LA is connected to the RV. So there is the atrioventricular discordant, and also the blood vessels are malposed. Pulmonary artery is connected to the LV and aorta is connected to the RV. So there is double discordant. This is CTGA with pulmonary atresia. You can see the hypoplastic RV because no communication from the LA to the RV, and only the source is the small restrictive VSD that falsifies the RV. Now, in less than 20% of the cases, in type 2, there may be associated other lesions like the coarctation of the aorta, which is about 0.8% of cases. There may be persistent left SVC, the aortic arch may be on the right side, and the atrial appendage may be juxtaposed. So these are the conditions associated with the type 2 tricuspid atresia, and then it is actually less common with the type 1 tricuspid atresia. Now the hemodynamics or the pathophysiology. You can see already you could see that there is no communications in tricuspid atresia from the RA to the RV. So the systemic venous blood that are coming into the RA that enters through the ASD or the PFO into the LA, and from the LA that blood mixed with the venous, the pulmonary venous blood, and from LA the pulmonary venous blood enters into the LV, and from the LV through the PSD, this mixed venous blood is then enters into the pulmonary circulation. But in case of type 2, this flow is mixed venous and the pulmonary venous and the systemic venous blood coming to the LV and through PSD, it then passes in a type 2 through the aorta into the system. Now, the clinical feature, as I mentioned already, because of the diverse anatomy and the pathology, the clinical feature also differs, or it depends on the type of the tricuspid atresia. So in case in type 1 with the decreased pulmonary blood flow that we see in the type 1A or in type 2B. So in that particular case, the baby actually born with the normal birth weight. Although the complex the cardiac anatomy, but the baby is born with the normal birth weight and height. There is cyanosis at birth, and then if you do the pulse oximetry, we'll see it is percent saturation of the oxygen less than 90%. Baby will be tachypneic, there will be tachycardia, and the feeding will be subsequently difficult. There will be suck post-suck cycle, and baby will also develop in the later part of his infantile life, that is the hypercyanotic spell. And the mechanism of this development of the hypercyanotic spell, it is same like that of the tetralogy of the fellow, because the decreased pulmonary blood flow, whether there is infundibular stenosis or the pulmonary stenosis, causing the hypercyanotic spell to develop. Now, in case of type 1C, or when there is increased pulmonary blood flow, or the type 2C, what actually happened? This baby may not be cyanotic at birth, but may present with the signs of the heart failure. And the signs of the heart failure, as you know, that there will be dyspnea, there will be feeding difficulty, there will be excessive sweating because of the pulmonary overcirculation. Patient will have the tachycardia, there will be hepatomegaly, and also the fatigue. Patient will have the feeding difficulty. The only fatigue is the feeding difficulty in the early infant and the neonatal age. So in case of type 2 with the restrictive VSD or the infundibular stenosis, here, as I have mentioned, in the type 2, there is transposition of the blood vessels, and the aorta is on the right side. So if there is restrictive VSD or there is infundibular stenosis, so there is decreased flow in the systemic blood. So because of this decreased systemic blood flow, the patient will be hypertensive. Patient may even develop the shock. So there will be acidosis, and mostly the metabolic acidosis. And then if this type 2, we know that it is associated with the other anomalies like the coarctation of aorta. So if it is associated with the coarctation of the aorta, then there may be absent or the weak lower extremity pulse. And then tricuspid atresia with the restrictive ASD or the PFO. If the tricuspid atresia is associated with the restrictive ASD or the PFO, then what happens? This baby will be severely dyspneic, and there will be hugely dilated right atrium. Baby will be cyanotic, deeply cyanosed. You can see the deeply cyanosed baby right after the birth. There will be marked hepatomegaly because of the chronically congestive hepatopathy. If we want to see the jugular venous pulse, then we can get the prominent jugular venous pulse. And this baby will also have the low cardiac output state because there is restrictive VSD. So the systemic venous blood cannot actually completely evacuate into the LA. And then the LV filling will also be decreased. And then because of the decreased LV filling, left ventricular end-diastolic volume will also be decreased, and the stroke volume will also be decreased. So the baby will develop the hypertension. There will be poor peripheral palpation, and this patient may also develop the shock and acidosis. So if we examine the precordium of a baby born with these types of congenital anomaly, so what we can get the left ventricular apical impulse, because here the left ventricle is the dominant and it is dilated, and we'll get the apex LV impulse. So we can also get the thrill due to the pulmonary stenosis if it is there, in case of type 1B or type 2B, or if there is small VSD, we can also get the hollow systolic murmur in the subsequently. And then the heart sound, it will be single and loud because there is no component of the tricuspid valve. Only the mitral component will produce the sound, but the sound will be loud. We can get, I have already mentioned, the hollow systolic murmur of the VSD, and then may also get the functional, the MDM in the apical area of if there is pulmonary overcirculation. So there will be prominent jugular venous. Beside the precordial examination, we will also get the prominent jugular venous wave. We can get the clubbing after the 3 to 6 months of after the 3 months or the 12 weeks of the after delivery. then because of the polycythemia, there will be conjunctival congestion, because we know the all cyanotic patients will have the polycythemia because of increased erythropoietin secretion, secondary to the hypoxia, and then this erythropoietin will cause the increased RBC production, and the baby will develop the polycythemia. So there will be conjunctival congestion, and this cyanotic baby may also develop, like other cyanotic congenital heart disease, the cerebral abscess. Patient may also develop the thromboembolic complications and a stroke later on. There will be relative anemia because of the patient cannot cope up with this polycythemia. So patient will develop the relative iron deficiency anemia, and then the growth will definitely be hampered. Patient will be failure to thrive. So how to diagnose these conditions? We can very well diagnose this condition in the prenatal period by the fetal echo or by ultrasound scan as early as 18 to the 20 weeks of the gestational age. And in the postnatal life, if the baby born with a cyanosis, then how we approach to this baby? So what should be our approach? First of all, if the baby born with the cyanosis, we have to examine the baby from head to toe, and we'll see the baby is bluish in color. So there is the cyanosis. If we do the pulse oximetry, we can see the percent saturation of the oxygen, it will be less than 90%. Then we have to observe, second, the breathing pattern. We have to observe the breathing pattern because the weak or irregular respiration is often associated with a weak sucking reflex, and this is secondary to the central nervous system cause. And the baby may also develop the convulsion and the generalized depression that also suggests the central nervous system cause. In contrary, an infant with the primary cardiac or the pulmonary disease displays vigorous or the labored respirations with the tachypnea. So if we observe the breathing pattern, we have to see whether the baby is tachypnic. If there is tachypnea, then definitely this tachypnea and cyanosis may be secondary to either respiratory or the cardiac cause. So differentiate between the respiratory cause of cyanosis or the cardiac cause of cyanosis or the primary pulmonary hypertension that can cause also the cyanosis. So we have to do a hyperoxia test. And this hyperoxia test, what is this hyperoxia test? This hyperoxia test, this test actually distinguishes the cyanotic congenital heart disease from the pulmonary disease. So before doing this test, we have to do an ABG. And then after the giving 100% oxygen for about 15 minutes to the baby, either by the high flow nasal cannula or by the CPAP, then we have to do the ABG again. So neonate with the cyanotic congenital heart disease do not usually have significantly raised arterial partial pressure of the oxygen during administration of the 100% oxygen. And this arterial partial pressure of the oxygen, it will be less than 100 millimeter of mercury, and it confirms that this is secondary to the cyanotic, that cyanosis is secondary to the cyanotic congenital heart disease. But then the PO2 generally increases significantly in pulmonary diseases as ventilation perfusion inequalities are overcome by the oxygen administration. And in this particular case, you can get the partial pressure of the oxygen more than 150 millimeter of mercury. But if it is in between the 100 and the 150 millimeter of mercury, then we have to evaluate for the other causes or of these conditions, because we can get in particularly truncus arteriosus or in the total anomalous pulmonary venous drainage, sometimes the partial pressure of the oxygen may be a bit 100, but subsequently it will be less than 100 millimeter mercury. So if we do the hyperoxia test, then we will be able to differentiate that whether the cyanosis is secondary to respiratory or the cardiac cause. So our diagnosis with this test will confirm that yes, it is the case of the cyanosis and it is secondary to the cardiac cause. If it is secondary to the cardiac cause, to find out what are the cardiac conditions that can cause the cyanosis at birth, then we need to do some investigations. So in the investigations, if we do a chest X-ray for tricuspid atresia, the chest X-ray will be like this. The heart will be globular. In case of particularly type 1B and type 2B, because there is pulmonary stenosis and there is decreased pulmonary blood flow, the lung pills will be oligamic. But when there is the increased pulmonary blood flow, particularly in case of type 1C or the type 2C, we'll get the increased pulmonary vascular bed. In both the lungs, there is the plethoric lung field, and there is also the cardiomegaly. So if we do an ECG, if we do the ECG, what we see in tricuspid atresia, in the ECG, you can see here, in lead 1, there will be tall R in lead 1, and in lead AVF, there is the deepest in the lead AVF. So for quick assessment of the ventricular axis, we know that the ventricular QRS axis It determines what? It determines the direction of the frontal plane ventricular force in which direction. So the cumulative force in frontal plane QRS axis, it is directed on this, the hexaxial reference system, it is directed on the left side because of the lead one is here. So lead one, the negativity is here and the positivity you can see it is here. So if the lead one is up, so it is almost in that particular area, and the lead AVF positivity is in the below and negativity is in the upside. So lead AVF, you see here, it is the deep ACE is in the lead area AVF. So the axis will be in that particular direction between the 90 degree to this 0 degree. So it will be in this area. So the axis, this type of axis, it is called the left superior axis deviation. The axis will be on the left side and it is superiorly flexed. So the ECG will say the left superior axis, and in addition to the left superior axis, so for quick assessment, we have to see the lead 1 and AVF for axis determination. The total, the force, the cumulative force is directed in which pathway. And then also, we also get the tall peaked P wave in lead 2, also in the chest precordial leads. You can see also the precordial leads, the tall peak P wave that indicates the right atrial enlargement. So if we summarize the ECG, so in type 1, we will get the left superior axis. It is the tall R wave in lead 1 and deep S wave in lead AVF. There is right atrial enlargement. We will get the tall peak P wave in lead 2 and also in the chest leads. In type 2, what happens? There will be also the cumulative force. It is leftward directed, but then superior axis and the inferior axis that will be evenly distributed because of the transposition. And in patient with the increased pulmonary blood flow, often shows the tall peaked R wave and deep Q wave in the lead B6, because in case of over pulmonary circulation, there will be increased left ventricular filling, and this deep Q wave will determine, yes, that is the left ventricular volume overload. So if we do the echo actually it is the confirmatory for this diagnosis of the tricuspid atresia. In a normal heart, in the apical fourth chamber book, transthoracic, you can see both the valves are moving normally, and you can also see the chambers, the right atrium, left atrium, and also the ventricles. But in case of tricuspid atresia, what happens? This particular area, the tricuspid valve area, there is no valve is moving. Rather, there is hypoechoic structure or the tissue that actually blocks there is no flow from the RA to the RV. And this RA is also hugely dilated. You can see that the LA is hypoplastic or it is compressed by the RA. And then the only valve, that is the mitral valve, is moving. LV is dilated, and then the RV, it is hypoplastic. So echo will give the definite book picture of the tricuspid atresia. And if we do the color Doppler, then you can see here there is no flow from RA to the RV. RA is dilated, and you can see here also there is the ASD, and it is shunting from right to left side. And ASD here in this particular case is also restrictive. You can see the flow accelerations, and then there is nothing wrong in the mitral valves, and there is restrictive VSD that actually causing the filling of the RV, and then subsequently the pulmonary circulations. So cardiac catheterization. Next is the cardiac catheterization. Should we do the cardiac cath or not? Actually, for diagnosis of tricuspid atresia, cardiac cath is not an indication. But in conditions where we need to do the cardiac catheterization, these are. So what are the indications? The indication is number 1, to identify the course of the pulmonary blood flow in type 1A or 2A. That is when there is pulmonary atresia, then we have to find out that where from the lung is getting the blood. So in particular, searching these conditions, you need to do the cardiac cath, and you will see that yes, the pulmonary circulation is getting blood from a collaterals or multiple collaterals, and that can be connected to the PA also, the hypoplastic PA that is supplying both the lung fields. And if the previous surgery is done, so to determine the hemodynamics and following the previous palliative surgery, like if the BDG is done, the bidirectional cleanse done, then we have to measure the PA pressure before doing the Fontaine's next stage palliation, that is the Fontaine procedure. So we have to do the cardiac cath, and you have to introduce the catheter through this right or the left internal jugular vein to get access to the pulmonary artery, and then we can measure the PA pressure, and we can also, by injecting the dye, we can also see the anatomy of the pulmonary artery, whether there is any distortion or any obstruction is there or not. And the number 3 indication, this is very much important. Sometimes the tricuspid atresia, as I have mentioned, associated with the restrictive ASD or the PFO. When there is restrictive ASD or the PFO, for survivability, if this PFO can be closed at any time after birth, and the small ASD that can also close after birth. So there will be no systemic venous flow into the going to the pulmonary circulation, the patient will die. So to save the life of the patients, the urgent percutaneous interventions we have to do, that is the balloon atrial septostomy. We can introduce a balloon tip Ruskin atrial septostomy balloon through the venous approach into the RA. Then from RA through the small ASD or the PFO into the LA. And in the LA, what we do, we can actually deflate this balloon, and then suddenly pull back of the balloon causes your creating a hole that is larger, and that that will allow the systemic venous blood to go into the LA. And the number 4 conditions, when associated anomalies not clearly defined by the echo. If echo is not, you are not sure that the associated anomalies cannot be seen in the echo, then also we can do the cardiac catheterizations. So if you do the cardiac cath, what you see actually, in the typical view of the tricuspid atresia, you can see here the LB is dilated. There is the restrictive VSD that actually falsifies the hypoplastic RV. And here the great vessels also you can see. Great vessels are here in this particular case normally related. The aorta is connected to the LV, and the PA is connected to the hypoplastic RV. And there is the, in this particular case, also the pulmonary stenosis. You can see the central jet and the post-stenotic dilatation of the MPA. So this is type 1B of atresia, which is more common. Then we can also do the cardiac CT or MRI. So in spite of the cardiac cath, and between these two, cardiac CT or the MRI actually it is the gold standard in evaluating the tricuspid valve and the RV dysfunction because of its both the spatial and the temporal resolution. And with MRI also, we can determine the RV function, the pulmonary regurgitation, and also we can measure the RV volume and other things. So, and this will also clearly view that there is tricuspid atresia, dilatation of the RA, no communication between the RA to the RV. And you can see here the LV is dilated and LA is getting supply from this ASD. And if we do the CT angio at all, so the CT angio will also be able to say that yes, tricuspid atresia can be diagnosed. And then this particular view I have shown here, it is the tricuspid atresia type 3 because you see already there is the ventricular inversion, and also the atrioventricular connection there is discordant. The red vessel is also, it is transposed. LV is connected to the PA and the aorta is connected to the RV. So there is double discordant, and the tricuspid valve, it is also atretic, and there is no communication between the LA to the RV. And then this RV is getting supply only through the VSD. And this in the summary, so how to diagnose the case of cyanotic congenital heart disease. In the summary, this is the very important slide to me. And then the students can remember this slide. So you can diagnose the cyanotic congenital heart disease, and you can also differentiate or narrow the differential diagnosis. So when a baby is born with cyanotic cyanosis or cyanotic congenital heart disease, you do the physical examinations. So we'll get the cyanosis. If you do the pulse oximetry, then we'll get the percent saturation of the oxygen. It is less than 90. And then to differentiate whether this desaturation it is because of the pulmonary or the cardiac cause, we have to do the hyperoxia test. That will reveal, yes, the partial pressure of the oxygen in the artery, it is less than 100 millimeter of mercury. So your diagnosis of cyanotic congenital heart disease is confirmed. But you have many conditions that can cause your cyanosis or the cyanotic congenital heart disease. These are the differential diagnoses. To narrow this differential diagnosis, we have to do some investigations. Like if you do an X-ray, so X-ray will reveal either, I have shown whether the pulmonary blood flow is increased or the pulmonary blood flow is decreased. So in conditions where pulmonary blood flow is decreased in X-ray, then do an ECG. If the ECG shows the left ventricular hypertrophy, if ECG shows the left axis deviation with dilatation of the RA, then your first diagnosis should be the tricuspid atresia. If the X-ray chest shows decreased pulmonary vascularity and ECG shows the right ventricular hypertrophy, so the first diagnosis, it is the tetralogy of the fellow. But in tetralogy of the fellow, what is the ECG findings? You will get the right axis deviation. Here in the tricuspid atresia, we will get the left axis deviation. You can get the right axis deviation in the other conditions. In case of the right ventricular hypertrophy, you will get these findings. ECG will show the right axis deviation in TGA, in total anomalous pulmonary finance connection. So if the X-ray chest shows the decreased pulmonary vascularity or the increased pulmonary vascularity, and your ECG will dictate by your this axis that whether it is a case of tricuspid atresia or it is a case of the other cyanotic congenital heart disease. In particular, when X-ray is showing the increased pulmonary vascularity, ECG shows the left ventricular hypertrophy. So this is a single ventricle physiology, most likely tricuspid atresia, but the other conditions of the cyanotic congenital heart disease like this persistent truncus arteriosus may also causes your the left ventricular hypertrophy. So to differentiate these two conditions, whether it is truncus arteriosus or it is TGA with the VSD, we have to do the echo. And echo is confirmatory. Echo will tell you everything that yes, this is not the TGA and this is not your persistent truncus arteriosus. You can see only the one truncal bulb in the truncus arteriosus. Here you can see both these things, and in this particular case, RV will be hypoplastic. And then actually the conditions I mentioned, the 4 conditions where we can do the cardiac cath. And then if you do not want to do the cardiac cath, and we can skip this cardiac cath, and we can do the cardiac CT or MRI, because this cardiac MRI now getting the popularity because of its less invasiveness, and in MRI also dictate the RV function, RV volume, and also the pulmonary the circulations. It will also say about the pulmonary circulations. So this slide is very much important in diagnosing a case of a cyanotic baby, and to actually narrow the differential diagnosis and to pinpoint your diagnosis. Yes, this is a case of tricuspid atresia. Now, after diagnosing a case of tricuspid atresia, so what is the management? So management is medical management and the surgical management. In the medical management, there may be pharmacological the drug therapy, or there may be percutaneous interventions. So in the pharmacological management, in the immediate neonatal period for type 1A and type 1B, so the treatment actually varies with the type of the tricuspid atresia. The clinical feature and also the management plan will also vary. So in case of type 1A and type 2A, where there is decreased pulmonary circulation or there is atresia of the pulmonary artery, what we should do, the patient we should put on the parenteral nutrition. We have to correct the acidosis if there is any acidosis. Then we have to start the intravenous prostaglandin to keep the ductus patent until the next stress palliation can be made or it is done. That is the in case of type 1A or 2A. So we have to do a aortopulmonary shunt or the Blalock-Thomas Taussig shunt. So till then we have to continue the prostaglandin infusion. And it is better because when we start the prostaglandin infusion, then the 2 major complications of the prostaglandin, number 1 is the recurrent apnea and another one is the hypotension. So to avoid this apnea, we can put the patient on ventilation, and the patient also may require the inotropic support. And moreover, this patient will subsequently go for the aortopulmonary shunt, and you need to do the ventilation again. This intubation and put on the patient mechanical ventilation. So it is better to keep the patient on ventilation well ahead of the surgical procedure. Then in case of type 1C or the type 2C, where there is pulmonary circulation increase, then in that particular case, we have to give the anti-congestive therapy with the diuretics, with digoxin, and sometimes when there is LV function is the poor, then we can add the angiotensin converting enzyme inhibitor, and subsequently, these patients will also need the neonatal surgical intervention, that is the PA bending, because the chronically over circulation in the pulmonary artery will cause the pulmonary over circulation that may ultimately leads to the pulmonary hypertension and even the pulmonary vascular resistance. That will also cause the LV filling overload, the diastolic volume will increase, and the LV failure. So this patient needs the PA bending at an earlier age, because subsequently if we do not do the PA bending, the patient may be inoperable for this PA bending and for the subsequent palliative surgery. So these are the pharmacological management in the immediate neonatal period. Besides, we can do the percutaneous interventions. These percutaneous interventions, that is the life-saving, I have already mentioned, the balloon atrial septostomy, or we may do the pediatric stenting, I will cover in the subsequent slides. And this cyanotic baby, actually, they need to maintain a good oral hygiene in the subsequent life and the infective endocarditis prophylaxis before any dental procedure. So in the percutaneous interventions, you can see here, we can do the emergency life-saving balloon atrial septostomy. I have already described, and we may also need to put a stent in the PDA if there is a small PDA in case of type 1A or type 2A, where there is pulmonary atresia and the pulmonary blood flow is totally depends on the this ductal dependent pulmonary circulation. So these are the percutaneous intervention and the surgical management. Surgical management, the goal of the surgery, you have to know what is the goal of the surgery. To provide adequate pulmonary blood flow and to avoid the extreme hypoxemia. So we have to provide adequate pulmonary blood flow to avoid extreme hypoxemia. So we need to do the palliative shunt, either in the form of immediate neonatal aortopulmonary shunt or subsequently the other palliative shunt like the Glenn operations or the Fontaine operation I will discuss in subsequent slides. And to prevent the pulmonary overcirculation also, not that we'll increase the flow, but then when there is increased flow, so we have to prevent the pulmonary overcirculation by place a band in the pulmonary artery, that is the pulmonary PA banding, to prevent the pulmonary overcirculation. And to preserve also, not only that we'll do the surgery and we'll not preserve the pulmonary artery, we have to also preserve the pulmonary artery anatomy for the subsequent surgery. So these are actually the surgical options. We have to do the palliative surgery and definitive surgery and the corrective surgery. So the tricuspid atresia, because of the diverse anatomical and the pathological condition, because of the diverse anatomy and pathology, if the tricuspid atresia, there is decreased pulmonary blood flow immediately neonatal period, we have to do the aortopulmonary shunt. And if there is tricuspid atresia with the transposition of the cateteris that is in type 2 associated with restrictive VSD, we can do the Damask stent cell operation or the DKS operation plus BT shunt. And then if there is increased blood flow, we have to do the PA bending in the immediate neonatal period. And then after that, in stage 2 operations, we can do the BDG or it is called the Hemifontaine in 3 to 6 months of age. And after the stage 2 operation, after 1 to 2 years of the stage 2, we can do the second definitive, the palliative surgery, that is the Fontaine operation. I will talk on this specific surgery later on. So here you can see the aortopulmonary shunt is connected between the subclavian artery and the pulmonary artery. This is known as the Blalock-Thomas modified Blalock-Thomas Taussig shunt. So the next stage, that is the definitive surgery of the capopulmonary connection, that is the bidirectional Glenn. That is actually done in 3 to 6 months of the age, in particularly type 1B, type 2B, or type 1A, or the type 2A as the second stage operation. In this Glenn operation, what actually the surgeons do, they cut the superior vena cava, the lower end that is connected with the atrium, and it is swept over, and it is connected with the right pulmonary artery as end to side anastomosis. And you can also see, if you do an angio, so you can see these connections and also the Glenn, whether it is functioning properly or not. And then in case of the type 2 with the restrictive VSD, then we have to do the Damask stent cell procedure, or in short, it is called the DKS. That is the operation where the MPA is connected to the ascending aorta. MPA is connected with the ascending aorta. Here you can see, because of this hypoplastic aorta, MPA is connected to the ascending aorta. In addition, the aortopulmonary shunt is also maintained. That is a Blalock-Taussig-Thomas shunt, it also in place. So this is called the DKS operation in type 2 with the restrictive VSD. So after this DKS operation, there are many modifications made in these DKS operations. In the classical DKS operations, the pulmonary artery is connected to the aorta using a patch. But nowadays, this technique is not actually preferred. Now the double barrel technique is applied, where the patch is not actually placed. The MPA is directly connected with the aorta in a way their patch is not required, and the aorta is getting supply both from the both valve, that is from the pulmonary valve and also from the aortic valve. And in type 3, the management should be individualized according to the anatomy and the hemodynamics. There is no individual management for this condition because we have seen these conditions actually associated with the more complex type of the tricuspid atresia. It may be associated with the truncus arteriosus. It may be associated with the corrected transposition. So the management, it should be individualized. And the PA bending I have already mentioned, in where there is increased pulmonary blood flow, you have to place a band in between the bifurcation of the, this confluence branch PAs and the pulmonary valve. So we have to place a band here to restrict the flow in the pulmonary circulation where there is increased pulmonary circulation in type 2C or the type 1C. And the Fontaine procedure, the definitive surgery, the final definitive surgery is the Fontaine operations. So the Fontaine operation in 1978, the Chusets et al., they have cited some criteria. If the patient fulfills these all 10 criteria, then this patient is suitable candidate for this Fontaine. These criteria were like the age at operation between this and the presence of normal sinus rhythm, normal systemic venous connection, normal right atrial size, and the normal pulmonary arterial pressure. That is, the mean pulmonary arterial pressure should be less than 15. Low pulmonary vascular resistance should be at or less than 4 units, and adequate size pulmonary arteries with diameter at least more than 75% of the aortic diameter, or you can do a McGinn ratio here. It should be more than 1.8, and there should be the normal ventricular ejection fraction more than 60%. So there must not be the mitral valve insufficiency and absence of complicating factors from the previous surgery like the pulmonary artery distortion. But nowadays, these 10 commandments reduced to only 4, even sometimes only 2. Because these conditions, because of the development of the surgical technique and also the medical interventions, this condition can be minimized. If there is no sinus rhythm, the intracardiac device can be placed, or even if there is heart block, the pacemaker can be placed, and then patient can go for this final definitive surgery. So if there is even the normal systemic venous connection, if it is not there, so surgical techniques are there, they can compensate it, and the surgery can be done before doing this Fontaine surgery. So now these 4 are the criteria. If patient fulfills these 4 criteria, I have highlighted, the patient is suitable for this Fontaine. And age is not actually the factor now. We can do the surgeons can do the Fontaine surgery even at 6 months to 1 year after the Klein operation, at 2 to 3 years of the age. So what is a Fontaine surgery? So Fontaine surgery can be done in one stage or in a step. The stage operation. First stage is the BDG or the Glenn shunt, and second stage you have to place a conduit between the IVC and also the pulmonary artery by placing a conduit the animation. You can see the extracardiac Fontaine, but Fontaine operations can be done the intracardiac by placing an atrial baffle within it, and there may be fenestration can also be kept. So there is a pop-up. If there is any increased pressure in the pulmonary circulation, so the blood can shunt it here into the venous atrium and then can go into the LV and ultimately into the pulmonary circulation. So the Fontaine surgery, nowadays, the only definitive surgery, particularly country like us where the corrective surgery, it is not yet done and not possible maybe. We are hopeful that in future the corrective surgery can also be done in our country also. But before that, that is the only definitive surgery for this type of complex congenital the cyanotic heart disease. So what is the corrective surgery? The corrective surgery, it is the cardiac transplantation. This can be done as a primary procedure. We know that the first cardiac transplantation in a human, it is done in 1967 in the South Africa, Cape Town, South Africa. Since then, because of the improved development or the improved technique, surgical technique, and also the immunosuppressive therapy, this corrective surgery is now a good option for patient with the complex congenital heart disease, particularly with the hypoplastic left heart syndrome or the Epstein anomaly, even the tricuspid atresia, the cardiac transplantation, where the diseased heart actually is removed, keeping the atrium intact, and the donor heart is replaced. So the cardiac transplantation can be done as a primary procedure, or it can be done after the Fontaine surgery when the patient develops the complications and if the complications are not manageable medically. Now the summary again. Summary of this complex type of cyanotic heart disease or the univentricular heart. Particularly, this is the Indian, according to the Indian guidelines, And those who have attended the class of our respected Anita Saxena ma'am, she has presented this. And then, so according to that things, you can see here, if the patient reports less than 3 months of pace, and then patient the the pulmonary arterial hypertension, if it is there, then you have to put a PA band, and then we can follow up and for subsequent the Glenn operation later on. If the patient present less than 3 months with the pulmonary stenosis, then you have to monitor the saturation. If the saturation is less than 75%, then you have to do a aortopulmonary shunt. If the saturation is more than 80 or 80%, then we can follow up and ultimately we can do a BDG operation in less than 3 months. So if the patient presents after 3 months, what happens? If there is the pulmonary arterial hypertension, then you have to do a cardiac cath for operability. If the cardiac cath shows the yes, the patient is still operable, so we have to place a PA band there, and we can follow up the case, and we have to do the this cardiac cath again to measure the PA pressure. If the PA pressure near normal, or if it is less than 50 millimeter mercury, then we can do the Glenn operation subsequently. But if the cardiac cath shows yes, the patient is not operable, then we have to follow up the case, and medical management is the only option for this unfortunate child. But if the patient presents after 3 to 4 months of pace, and if there is pulmonary stenosis and PA pressure is normal, we can directly go for the Glenn operation. And after the Glenn operation, at least after 1 or 2 years, we can do the Fontaine surgery at 4 to 7 years of the age. So this is the summary of the surgical options available for this type of complex cyanotic congenital heart disease. And what are the complications? So complications related to the surgery. Immediate complications, there will be low cardiac output. Why? Because the RV force in Fontaine surgery or even in BDG, what happens? The subpulmonary ventricle, that is the RV, and also the force added by the LV, it is absent. And that's why there will be definitely, the flow will be little sluggish than what is normally we see in the pulmonary circulation. So patient initially may develop the low cardiac output, and gradually the patient will adjust with this low, the new hemodynamics. Patient may develop the heart failure immediately, we have to manage it. Then patient may develop the pleural effusion, particularly if there is the collaterals, aortopulmonary collaterals, the patient will develop the pleural effusion, it will be prolonged. Then we have to catheter embolize these collaterals. There may be thrombus formation immediately, so we have to break the thrombus either by thrombolytic agents or by the surgical removal of the thrombus. And immediately the patient may develop the hepatic congestion, and the liver enzyme may be also increased, and we have to follow this liver enzyme, and we have to manage the patients accordingly. And the late complications are surgical complications, mainly the arrhythmias. More common is the supraventricular tachyarrhythmias, but other types of arrhythmia can also happen. The patient may develop the ventricular dysfunction. There may be the atrioventricular valve regurgitation on the left side. There is the mitral valve regurgitation. Subsequently, patient may develop. There may be pulmonary arteriovenous fistula. We know that in case of the Glenn operation, or even after the Fontaine operation, or the total pulmonary, the circulation, there is the hepatic inhibitory factor. It is not there in the pulmonary circulation. So there will be angiogenesis and the formation of the arteriovenous fistula because of the, inadequacy of the hepatic inhibitory factor. If the patient develops the pulmonary arteriovenous fistula, so this is a complication. And then there may be Fontaine pathway obstruction, and ultimately there is a condition which is called the failing Fontaine. The Fontaine is unable to maintain its circulation into the pulmonary bed, and the patient will develop the sign symptoms of the systemic venous blood hypertension. So the patient may also develop the thromboembolic complications. Patient for that particular case, it needs to continue the anticoagulant therapy for lifelong. Usually after BDG, the patient can be placed on a antiplatelet, but after Fontaine, it is better to give the patients or to put the patients on the anticoagulant therapy for lifelong to avoid this type of complications. And then there is congestive hepatic. The patient may also develop the portal hypertension, even cirrhosis later on. And the most deadliest complications, it is the protein losing enteropathy. For this particular case, the patient may develop the hypoproteinemia. Subsequently, there will be increased hydrostatic pressure, and the patient will develop the edema because of the low the osmotic pressure and ultimately ascites. And this type of patients will definitely have some exercise intolerance, and gradually there may be arterial dissociations. So these are the complications of the patients after the surgery. The important one and the deadliest complication is the protein losing enteropathy. I have one slide for the protein losing enteropathy. And for the protein losing enteropathy, what is the cause? Exactly, there is no definitive cause as yet it is mentioned for this protein losing enteropathy and for the increased venous pressure. But there are hypotheses or there are the pre-exciting or the predisposing factors, like there may be increased pulmonary vascular resistance. Secondary may be due to the Fontaine pathway obstruction, or pulmonary pressure may be increased after surgery. And then because of this increased systemic venous pressure, what happens? Because of the increased systemic venous pressure, there may be increased mesenteric vascular resistance. Patient will develop the intestinal vascular congestion, then intestinal mucosal injury that may interfere with the protein absorption, ultimately the loss of the protein with the stool. So patient will develop hypoproteinemia, edema, and ascites. So there is another channel beside the vascular channel. There is another vascular channel that is called the lymphatic vascular channel. The pressure will also increase because of increased systemic venous pressure. This will also cause the dilatation of the lymphatic vessels, dilatation of the thoracic tract, ultimately drainage of the thoracic tract. It will be hampered. We know that thoracic tract drain into the innominate vein at junction of the right internal jugular and the innominate vein. Because of the systemic venous pressure, this drainage will be hampered. Patient will develop the chylothorax, and the spillage of this, the lymph into the intestine, and the patient may develop this protein losing enteropathy as a whole. If the patient develops this protein losing enteropathy, then what is the management? Actually, the patient should be managed aggressively, because I have already mentioned this is a deadliest complication, because after the patient develops this protein losing enteropathy, the 5-year survivability is almost less than 50%. So we have to manage the patient aggressively. We have to aggressively reduce the central venous pressure by your diuretics, by the angiotensin converting enzyme inhibitors, and also when there is the LV dysfunction, we can also add the pulmonary vasodilator therapy. Then we can add the systemic anti-inflammatory drugs like the corticosteroid. We may need to give the heparin, and the patient as there is hypoalbuminemia, so we have to give the parenteral albumin. And regarding the diet, patient should be on the low salt diet, and we can give the medium chain triglycerides, because we know that the low and medium chain triglycerides, these are directly absorbed into the portal venous blood bypassing the lymphatic channels. The long chain, the fatty acid or the triglycerides, they need to formation of the chylomicron, and ultimately they absorb into the lymphatic circulation, and then they into the systemic venous circulations. So as the patient develops the systemic venous hypertension, so we can give the patient medium chain triglycerides that will directly absorb into the portal venous blood bypassing the lymphatic channels. And if there is any collaterals, or if there is any arteriovenous fistula, that can also be embolized by the catheter intervention, by coil embolization of the collaterals or the fistulas. And if this all above management fails, then we have to do the corrective surgery. The only one option, it is the cardiac transplantation. Now the prognosis of this particular condition, without treatment, the survivability up to 1 year, it is 10%. And before the modified Fontaine, percentage of the people reaching the adult actually 50%. Because the earlier the classical Fontaine was done, classical Fontaine operations, here only the right atrium is directly connected to the pulmonary artery, but in modified Fontaine you have seen here the pulmonary artery, the SBC is connected with the RPA, and IVC blood is directed into the pulmonary circulations either through intracardiac or through the extracardiac conduit. And after modified Fontaine, the 90% of the patients survive up to the age 30, 80% of the patients survive up to the age of 40, and at 40 years of age, only 41% of the patients remain free from the serious events, the complications I have already mentioned. And this particular, the figure I have taken from the journal, and that is published in 2018 in the American Journal of Cardiology. So after the operation, or even before the operation, we need to follow up these patients before surgery also. So before surgery is done, we have to follow up the case for saturation, monitoring the saturation and patient, whether the patient develops the LV failure or not. Then we have to manage the patient accordingly. And after surgery also, after stage 1 and after stage 2, we have to follow up the case. And what will be the follow-up schedule? Follow-up schedule, it is, I have not mentioned here because it is individualized, and it is it differs in the institute to institute. Patient with the Fontaine operation, you need to follow up the case lifelong. Patient after BDG, you need to follow up the case through a schedule, like you can follow up after BDG 1 month. Normally in our institute, we follow up after 1 month, 3 months, then 6 monthly, and then yearly. So the follow-up schedule, it can be, the individualized, and it differs from institute to institute. But important one is that we have to keep the follow-up continuing up to throughout the lifelong, throughout the life. Now in each follow-up, what are the checklists? The checklists are, in each follow-up, you have to examine the baby for his somatic growth, pivotal development, whether the patient is distinct or not, whether there is any dissociation, and evidence of systemic venous congestion. So if there is any evidence, we have to monitor the case and we have to take the measures immediately. So in the investigation part, we can do the XHS to see the pulmonary circulation. We can do the ECG, so to see the arrhythmia, and also the echo for the pulmonary blood flow, whether it is pulsatile or non-pulsatile, whether there is any thrombus. We can also see the LV function and also the AV valve regurgitation. And we can also bypass this. I mean, we need to do the cardiac CT or the cardiac MRI when indicated. If it is indicated in the follow-up, then we can also do this cardiac CT or the MRI. And then we have to also assess the liver status, because I have already mentioned the patient developed the hepatic congestion and ultimately the cirrhosis of the liver, or maybe the portal hypertension. So that is all about my presentation. Thank you very much for your kind attention and sincere listen. Thank you very much for your passion shared.
Thank you, sir. Thank you very much for your nice presentation. Now I would like to request our respected mentor, Brigadier General Professor Nurul Nahar Fatima Begum, to say something about our today's class and conclusion of the session.
Okay, thank you, Nazmul, and thank you, Colonel Firdaus, for elaborate presentation of the tricuspid atresia. So this today is our 9th lecture, and before that, in our previous 8 lectures, we have learned, all the students who are attending these classes have already gone through the basics of the pediatric cardiology. So today we have started our first class on a disease and its individualized management. So if you recapitulate from your old previous knowledge of the previous lecture, you can get support to understand today's lecture. And today's lecture is what? It is a case of management of tricuspid atresia. So tricuspid atresia, it is a huge subject and it is a symbol of single ventricle heart. So this is the commonest available single ventricle type of anatomy in our common practice. So we have selected this tricuspid atresia to teach you about the management of the single ventricle heart, like when we'll go for the Glenn, what is Glenn, what is like Damascus stencil, what is like Fontan, what are the Fontan's criteria, what are the modified criteria, and so on. So it is a case of cyanotic congenital heart disease. So whenever you will see a case of cyanosis and you are suspecting a tricuspid atresia, most importantly, you need to consider on your pulmonary blood flow. So if the pulmonary blood flow is totally obstructed, if the pulmonary blood flow is partially obstructed, or it is an unrestricted pulmonary blood flow. So depends on these 3, management depends. So if there is no blood flow, so you have to think about like management of the pulmonary atresia. If there is too much blood flow, you have to think about like restricting the blood flow by giving a PA band, because in this patient, biventricular repair is not possible at any time. Only definitive treatment is the cardiac transplantation. So biventricular repair is not possible in a case of tricuspid atresia. So our aim is for single ventricle repair. So if there is too much flow in the lungs, we will not get any opportunity of the biventricular in future because of the high pulmonary vascular resistance and the criteria like Firdaus has mentioned. If the mean pressure is more than 15, then it will not fulfill your criteria. So you have to be careful once you diagnose tricuspid atresia and with the increased pulmonary blood flow, that you should do the PA bending at the very earliest moment. And then if there is too little flow, then you have to go for the PDA stenting. Even in some case of the small VSD, small VSD also pose too little pulmonary blood flow. Even if there is no pulmonary stenosis, only there is a small VSD. So that is the only way of cardiac output to the lungs. So if it is too much restrictive, then you have to enlarge that VSD. If the patient is very small and if surgery is not feasible, in that case, you have to place a stent in the VSD to enlarge that VSD. We have experience of placing stent in 2 of our cases where we are unable to do anything. We are not getting any surgical help. So what we did stenting of the VSD so that there will be some blood flow to the pulmonary circulation. Regarding the complications of the Glenn operation and the Flunton, Firdaus has mentioned about all the complications, but what we faced in few of our cases that immediately on the 2nd or 3rd day post-operative, I have seen in our hospital also when the charity team came from Saudi Arabia and also from the Qatar. Once we have seen that the flow from the SBC to pulmonary artery was totally stopped and there was blockage of the site of anastomosis. So we took the patient immediately to the cath lab and then we placed the stent over there. So that patient is still coming to us for the follow-up with the stent in the site of the connection of the SBC with the right pulmonary artery. So there are many kind of complications which may happen even in the Fontan tunnel. There may be some obstruction. The interventional cardiologist is supposed to open those. Even if there is a fenestration left open and which is not necessary, then we can close that fenestration even by doing a SD device closure. And even we can create some fenestration if there is too much of the pulmonary pressure or there is too much systemic pressure, we can get rid from that pressure by creating fenestration also. So there are, for the interventional cardiologist, there are many opportunities to help the surgeon. And this is a case where the surgeon and the cardiologist, they work side by side and they work together to bring a good outcome for the patient. We know that there is no definitive surgery for this tricuspid atresia, and what we are doing we are doing palliation. Fontan circulation is a palliative circulation. It is not an exit circulation of like a pulmonary separate circulation and a systemic separate circulation. Here, ventricle is not participating in pumping the blood into the lungs. So there is chance of what are the complications Firdaus has mentioned, like protein losing enteropathy and many other things like formation of arteriovenous collaterals. And when I was taking training in Saudi Arabia, I was so much worried about Fontan because every time we had 2 or 3 cases admitted in our ward with the protein losing enteropathy. And we were busy calling the dietitian to prepare MCT diet and so and so. But nowadays, I have seen that our outcome has improved a lot and we are not getting any case of protein losing enteropathy in my experience in Bangladesh. Our Fontan patient, they are coming back from the India. Most of our surgery are doing by the Indian surgeons. Most of our Glens are doing by them. But so far, I have not seen any cases of formation of the arteriovenous collaterals or development of the protein losing enteropathy. In that case, we are very lucky. So with this, I would like to thank Firdaus for giving a very elaborate lecture on tricuspid atresia, and I think who are attending this class today, they will be immensely benefited. And this is our aim of conducting this lecture series. I want every one of the pediatric cardiology trainee who are taking training in fellowship or in the MD, they should be trained properly. They should have thorough background knowledge, thorough theoretical knowledge, so that they will be able to make their own cases nicely in future. Thank you, everyone.
Thank you, everyone, for kind attention and participation. With this, we can conclude our session. Allah Hafiz. Assalamu alaikum.
Thank you, Nazmul.
Thank you, Firdaus bhai, for excellent and nice presentation.
Oh, thank you very much. আপনি আছেন
It
না?
was really
ভয়ে আছি যে
elaborate.
সাতজন না আবার আমাকে ধরে ফেলে কোথায়।
না ধরতে চাইছিলাম, চিন্তা করলাম যে আমি নিজে জানি কম, The RVDCC থাকলে কি করবেন? What will do for the RVDCC?
আরবি ডিসিসি থাকলে মানে ডাবল চেম্বার।
No. If there is a right ventricle dependent coronary circulation,
Yes, in case of the
RVDCC.
correct. So in that case, the option is very limited. If there is right ventricle dependent the coronary circulations, we cannot reduce the right ventricular pressure because the patient will develop the coronary insufficiency, and then actually the definitive surgery is not possible. Only thing is that we can do the aortopulmonary shunt, and actually, and with that the patient will continue his life. That's what is I know. Because we cannot reduce the
Thank you.
RV pressure, we cannot reduce because if we reduce
Yeah.
RV pressure, in that case there will be definitely coronary insufficiency,
Yes.
and then
Yes.
patient will develop the MI. That's why.
Okay. Thank you. Thank you.
Thank
Sir.
you very much.
Thank you, everybody. Sorry, we cannot lengthen our session more because of the time is coming very soon. Thank you, everyone, again.
Thank you. Salam sir, Asin Salam sir, thank you sir.
Thank you.
Sir, thank you very much. Allah sir.
Very nice lecture. Excellent. Excellent delivery. You left no stone unturned.
Sir,
Excellent workup.
thank you sir. Thank you very much.